Welcome to the second part of cell injury, cell death, as well as cell adaptation. We covered number 1, 2, 3 in our previous lecture and started number 4 here on our plan, and we'll dig in further into cell injury and cell death and explain the different mechanisms of that. And then after that, we will go over intracellular accumulation, pathologic calcification, and discuss cellular aging. Another important concept to understand with tissue injury and cell death is that the morphology of the cell injury or cell death, or the morphological change that you can see at the level of a cell, often lag behind the loss of cellular function. So a classic example of that is at the level of the cardiomyocyte. So if you have a myocardial cell that gets ischemic, this cell will become non-contractile or won't be able to contract after 1 to 2 minutes, as you can see here. Despite this, these cells that stop functioning are still in a state of reversible cell injury. So if the blood flow is redistributed to the heart, these cells can go back and function. But then after 20 to 30 minutes of ischemia, some of these cells will then start dying, where you can see that these cells will eventually die with the blue curve here. But if you took the heart muscle at this stage, at the level of the blue curve, you wouldn't be able to see that the actual cardiomyocyte have died at that point. If you had an electron microscope, after 2 to 3 hours from an injury, you might be able to see some structural change. But really, in terms of light microscopy, it takes 6 to 12 hours to be able to see these morphological changes at the level of the cell. And via gross morphological changes, by looking at, a piece of the heart muscle, that could take up to 6 to 12 hours. So again, the key concept is that there's a lag behind the cell death and the change of cellular function and the actual morphological change we can actually see on either microscope or gross morphological examination. When we talk about tissue injury that's irreversible, we typically mention that there's always two phenomena that are present that can characterize this irreversibility. One of them is that there's no ability to the cell to correct a mitochondrial dysfunction, despite the stop of the original injury. Obviously, mitochondrial function is essential to produce energy and ATP, and obviously if that's not corrected, that leads to an irreversible cell injury. And then the other key concept is a significant disturbance in the membrane function or the membrane integrity, again leading to an irreversible cell injury. Let's go through now a little bit of the morphology that we see when we talk about a reversible cell injury. The two main features that we see with reversible cell injury is cellular swelling as well as fatty changes within the cell. As you can see on this diagram here, on the left, these are normal ductal cells, and these have been injured. And in the middle there in B, these are example of reversible cell injury. So you can see that these cells have been are bigger or more swollen compared to the other cell, but there's also some lipid accumulation, as you can see here, around those cells, which represents these fatty changes. Other features that we see in reversible cell injury is that there is some membrane bleeding of the cell surface, as you can see here. So you can see these membrane blebs. If the cell had microvilli, you often would see the loss of these microvilli due to the swelling of the cell. Inside the cell itself, if with electron microscopy, you might be able to see swelling of the endoplasmic reticulum as well as the mitochondria. And you can also see eosinophilia in certain cells, as you can see here, typically due to decreased cytoplasmic RNA. when a cell undergoes necrosis, these are the main feature that you will see. So there's still some eosinophila, which is often increased, but more importantly, you will see that the membranes will start to be affected. That includes the nuclear membrane, so you can see that the nucleus can become smaller or shrink, which we call pycnosis. It can also fragment, which we call karyoresis, as well as it can also dissolve, which is called karyolysis. So change at the level of nucleus or a disappearance of nucleus within cell indicates necrosis. On top of that, there's also breakdown of other membranes, including the plasma membranes, as well as membranes of the organelles. And because of all these breakage of the membrane, including the plasma membrane, there's leakage of the enzymes from within the cell that leak inside the cell, but also can leak outside the cell. Inside the cell, it can digest intracellular component, and once it goes outside the cell, it also promotes inflammation. So there's often going to be inflammatory cells around the area of a necrotic cell or necrotic tissue. When we talk about necrosis, it's also important to understand that there's different morphology of tissue necrosis. We'll talk about 5 different types of tissue necrosis, including coagulative, liquefactive, caseous, fat necrosis, and fibrinoid necrosis. And you will see in the next few slides that the pattern of necrosis sometimes indicates a certain types of process. So the first one that's important to know about is coagulative necrosis. So coagulative necrosis is a very characteristic type of necrosis we see with infarction. When there's a lack of blood supply to an area, the cells typically undergo this type of necrosis. What's special with this type of necrosis is that if you look at the tissue itself, the underlying architecture of that tissue is typically preserved. So again, coagulative necrosis is quite common to see. Another type of necrosis that you will definitely see as a dentist in the future is a liquefactive necrosis. This typically is seen in bacterial infection. So when you do have an infection and you drain it, you obviously will often see this yellow liquid or creamy yellow substance, which is what we call pus. And that comes from the enzymatic digestion of the tissue. It basically liquefied the tissue. So you have basically a bunch of dead cells, a bunch of dead bacteria, and that forms the pus. So that's very characteristic of oral abscess or dental abscess, but it's also characteristic of brain infarct. So liquefactive necrosis is something you will definitely see and experience clinically. Another type of necrosis that we also talk about is caseous necrosis. Caseous means it's a cheese type like of necrosis. So you think about a nice piece of blue cheese, and that's what it would look like. So you can see here this area of the lung has been affected by caseous necrosis. Often it's associated with granuloma. So we often have an inflammatory region with a border, and the border of it encompassed what we call the granuloma, and the inside of it is often necrosed, leaving these cavity, and this is what we call a zone of caseous necrosis. You will see next year when we talk about tuberculosis, this is very characteristic of tuberculosis type of infection, which lead to these what we call caseating granuloma, again indicative of caseous necrosis. Another type of necrosis that we might also encounter is a fat necrosis, where you basically see focal area of fat destruction. That's often seen at the level of the pancreas. At the level of the pancreas, what can happen is that you can have, with necrosis, release of pancreatic enzymes, including pancreatic lipase, and these lipase will basically digest fat if it leaks out of the perineal into the perineal cavity. We often will see this type of necrosis with acute pancreatitis. And then the 5th type of tissue necrosis we'll talk about is fibrinoid necrosis, and in this type of necrosis we see immune complexes. We see immune complexes that get deposited along the wall of the artery, and then these immune complex with fibrin produce this fibrinoid substance, this bright pink amorphous substance around blood vessels, which also can lead to an immune reaction and necrosis of the cell. Again, we see that around the wall of the artery, and it's often related to immunologic reactions. So the next few slides, in the next few slides, we will discuss the different mechanism of cell injury. I apologize in advance. This is going to be a slightly dry material, but bear with me and hopefully we can get through this together. So when we talk about a cell injury, there's general principles that often happen. When you have a cell injury, typically the cellular response to that injury will depend on obviously the type of injury that, as we talked about before, with the different types of etiology for an injury to the cell. But another factor that's going to be very important in terms of the cellular response is going to be the duration of that injury itself, as well as the initial severity of that injury. And all of that will factor into the response of the cell. So that's definitely one key principle, but another key principle is that the consequence of that injury itself will also be dependent on the cell itself. It depends on the type of cell, the status of the cell itself that gets injured, how well the cell is able to adapt itself, as well as the different genetic makeup of certain cells. So there are some cells that are going to be able to withstand more of an injury compared to other types of cell. And overall, what leads to the cell injury is that you will have within the cell itself a functional and biochemical abnormality. And these abnormalities often affect the very important essential cellular component, which are essential for the survival of that cell. So you'll see when we talk about the different major mechanisms of cell injury in a few slides, we'll go through these different essential components that can get affected. And it's also important to know that this type of alteration of the essential component of the cell itself can be triggered by any type of injurious insult. You will see that depending on the type of injury, there's a favor towards certain types of injury or certain types of cell reaction. And again, we'll go through that as we go through the different mechanisms of cell injury. So let's go through them. As you can see here, there's 6 major mechanisms. The first one is ATP depletion. So obviously, for a cell to be able to survive, it needs to produce energy, and energy typically comes from oxidative phosphorylation, which produces ATP, and that's often occurs at the level of the mitochondria. So let's take an example of ischemia of a blood vessel. So you have a blood vessel that gets a blood clot, it gets ischemic, there's no oxygen supply to the tissue. Because of that, the tissue cannot produce ATP. So there's decrease in oxidative phosphorylation from the mitochondria, and because of that, there's decreased ATP. As soon as you have decreased ATP in the tissue, there's multiple systems going to get affected. So your sodium pump is not going to work well. That's going to cause influx of calcium, influx of potassium within the cell, and that leads to basically cell swelling. So you have swelling of cellular components, creating these swelling of the endoplasmic reticulum, swelling of the cell, as well as the creation of those blebs and the loss of those microvilli. On top of that, the lack of ATP will affect the ribosome. The ribosome will detach, and that will affect overall protein synthesis, which will also be decreased. And then the cell will also still want to be able to produce some energy. So to be able to produce some energy, often the cell will switch to an anaerobic glycolysis, which overall will decrease the pH within the cell due to the increased production of lactic acid. And a more acidic cell will lead to clumping of the nuclear chromatin, affecting obviously the nucleus itself. Eventually, this type of injury ends into necrosis. It can be reversible if it's of short duration, but if it continues to progress, often it will lead to necrosis. The second major mechanism of cell injury is mitochondrial damage or dysfunction. So we've kind of already talked about that in the previous slide. So, for example, if you have decreased blood supply from an ischemia, or if you have toxin or radiation that affects the mitochondria, often what happens is, again, a decreased ATP generation, more increased production of reactive oxygen species, which again leads to these cellular abnormality I've previously talked about, eventually leading to necrosis. So if you have this type of injury, decreased O2 supply, toxin or radiation, you often have necrosis of the cell due to that mitochondrial damage. But another way it can lead to another type of cell injury and cell death is if you have a cell where you have a damage to the proteins of the cell, or decrease survival signal, or damage to the DNA. All of that typically leads to an increase in pro-apoptotic protein from the mitochondria and decreased anti-apoptotic protein. So there's a disbalance between these pro and anti-apoptotic proteins, and these leak from the mitochondria, and this typically leads to apoptosis. So again, mitochondrial damage or dysfunction can also lead to apoptosis, and that depends on the initial signal. So again, if you have protein damage, decreased survival, or damage to the DNA, apoptosis is often the end result. Another third major mechanism is the influx of calcium. So if you have calcium that goes inside the cell, that will activate lots of enzymes within the cells that tend to damage cellular component. That could lead to membrane damage, they can lead to nuclear damage, and it can also affect the ATP by decreasing it, again, often leading to a significant cell injury. The fourth major mechanism is the accumulation of reactive oxygen species. So reacting oxygen species can be produced if you have a tissue that's radiated, if you have toxin, or if you have a tissue that gets reperfused. There's often a lot of production of reactive oxygen species, and these reactive oxygen species will affect lipids via lipid peroxidation, which can then lead to membrane damage. It will also affect proteins, so you can have protein modification, which can lead to breakdown and misfolding of protein, and you can also have damage to the DNA from these reactive oxygen species, leading to mutation, and again, that can also lead to a cell injury. A fifth type of cell injury that can also occur is an increased permeability of the cellular membrane. That can affect many types of membrane, including the plasma membrane, the lysosomal membrane, the mitochondrial membrane, and obviously this increased permeability can affect the function of the cell itself, leading to, for example, loss of phospholipids, breakdown of lipid products, damage to the overall cytoskeleton of the cell, again leading to this overall membrane damage. And as you know, membrane damage typically leads to eventual necrosis of that cell. And then finally, I've already alluded to a little bit earlier, we can also have six major mechanisms of cell injury, which is related to misfolding of protein or damage to the DNA. If you have lack of survival signal, protein misfolding, and DNA damage, often this will activate pro-apoptotic protein, and this typically triggers apoptosis. We will talk about apoptosis in the upcoming slides. So now let's discuss apoptosis. The definition of apoptosis is a regulated mechanism of cell death that helps eliminate unwanted and irreparably damaged cell with a minimal amount of reaction. So obviously we can eliminate cell via necrosis, but as we know, when you do necrosis, there's leakage of enzymes outside of the cell membrane, leading to inflammation. Via apoptosis, when a cell dies, typically there's no membrane damage, there's no leakage of enzymes outside the cell, and because of that, you don't have as much of a host reaction. As we talked about before, this can occur in physiologic situation, but also obviously in pathologic situation. When we talk about physiologic apoptosis, we typically see that in tissue where we want to maintain a constant number of cells. So if you have a cell number that increases, apoptosis can be triggered to again maintain that constant number. But obviously we can see apoptosis in pathologic conditions. So if you have a cell that's genetically damaged, it's injured too far, it can be repaired. in these type of scenarios, we want that cell to be eliminated without too much of a reaction. And again, that will often trigger apoptosis. When we look at a cell that is undergoing apoptosis, this is the typical morphology that you will see. So the nuclei often will become fragmented. The cell body will also become fragmented and shrunken. The chromatin of the nuclei also will become condensed. And overall, the cell will basically fragment in small little pieces called apoptotic bodies. And these apoptotic bodies will then be phagocytosed by local phagocytes. So you can see with these little arrows on the picture on the right, you can see that these cells normally took all of this space, but due to the shrinking of the cell that's undergoing apoptosis, you can see the space around it. So that's typical of apoptosis. When we talk about mechanisms of apoptosis, overall what occurs is that we have an activation of an enzyme called caspases. And the way caspases can be activated is via two pathways. There's an intrinsic mitochondrial pathway, and there's also an extrinsic death receptor pathway. So the first most common mechanism of apoptosis is the mitochondrial intrinsic pathway. This pathway is typically triggered when you have a cell that loses survival signal, when you have a cell that has a lot of DNA or protein damage. What happens is that you have the mitochondria that leak pro-apoptotic protein into the cytoplasm, and that will trigger the activation of caspases, leading to apoptosis. This also can be inhibited, so you have a counterbalance mechanism from anti-apoptotic members of the BCL family. These also can be activated if you have an induction of survival signal, if you have a lot of growth factor promoting the cell to survive. This anti-apoptotic protein can also be triggered, preventing an apoptosis of a cell. So you can see here in this diagram the mechanism of that mitochondrial pathway on the left. So again, you have DNA damage, not enough growth factor, misfolding of protein that will trigger mitochondria to produce pro-apoptotic protein. These will activate caspases. These caspases will then lead to fragmentation of the nucleus, breakdown of the cell, leading to apoptotic bodies, which are going to be phagocytosed. So this is the typical pathway of apoptosis. As you can see here, there's also regulator of apoptosis, which can also be activated if you have an increase in growth factor or increase in survival signals. The second mechanism of apoptosis is the death receptor pathway. This type of pathway is often activated when we want to eliminate lymphocytes that are self-reactive, or when we want to prevent damage by cytotoxic T lymphocyte. Typically, this apoptosis is initiated by an activation of a death receptor. It's from the tumor necrosis factor receptor family. You basically have something that binds to that receptor, and that will trigger caspase activation, again leading to apoptosis of that cell. So again, as you can see on the diagram here on the right, the death receptor pathway has this TNF death receptor. There's something that binds to it that can activate caspases, again leading to the same mechanisms of apoptosis. Another concept I'd like to talk about is also autophagy. So autophagy means self-eating, and that typically is seen via the mechanism of lysosomes. So lysosomes within a cell can lead to digestion of the own component of the cell. This autophagy is often seen in survival mode. So if you have a cell that's going through significant nutrient deprivation, the survival mechanism can be triggered, and what happens is that these digestion of the cell component produce energy, and that allows the cell to survive longer. So you can see here in this diagram, you have normal cytoplasmic organelle, you have nutrients that are deprived within the cell. Because of that, the autophagy signal are going to be activated. This will create autophagic vacuole, and this vacuole will then bind to a lysosome within the cell. The lysosomic enzyme will digest the cell component, and this will be used as a source of nutrient to allow the cell to survive longer. This here is a nice summary table. You can use this table for your exam. It really clearly outlines what happens with necrosis versus apoptosis. So the combination or the difference between the two is important to know, and I might use some of this for exam question. Now I'd like to briefly touch on intracellular accumulation. As you can imagine, these accumulation or deposit occur within the cell, but can also occur outside the cell within tissue. And they are the result of either excessive intake of a substance, a defective transport of the substance itself, or abnormal catabolism of the substance. Lipids can be deposited within cells, and this includes fatty changes when it's free triglycerides that are accumulated within cell. And as we talked about before, this is a manifestation of a reversible cell injury. It occurs often due to excessive intake, but also could occur due to defective transport. Another deposition of lipid that we will talk about, especially next year in our systematic pathology lecture, are cholesterol deposition. This is also due to defective catabolism or excessive intake, and this is a major problem leading to atherosclerosis in the smooth muscle cell of the vessel wall, potentially leading to ischemic cardiac events. We can also see deposition of pigments. Typically the pigments that are deposited tend to be indigestible. They can be exogenous or endogenous. The most common exogenous pigment is a pigment of carbon. You can also have deposition of lipofusin, which is a breakdown product of lipid peroxidation, as you can see here on the image on the top right by the arrows. And you can also see deposition of iron, often due to iron overload, as we can often see in hemosiderosis, which is due to excessive iron. And as you can see on the image on the bottom right, you can see these purple iron deposits. We can also see pathologic calcification within cell, and as you can imagine, these calcifications are due to an abnormal deposit of calcium salt. These deposits can be dystrophic or metastatic. When we talk about dystrophic calcification, we typically mean that these deposition of calcium are in areas where there's been a cell injury or cell necrosis. The sites of these injury and necrosis could leave areas of calcification, which are called dystrophic. The more concerning types of calcification are typically metastatic calcification, where we do see deposition of calcium in normal tissue, and this is often due to hypercalcemia, which is often a consequence of excessive parathyroid hormone release. And finally, another concept we will review is cellular aging. Obviously, all of our cells age with time, and aging typically is a result of the combination of either accumulating cellular damage, reduced capacity of the cells to be able to divide, or reduced capacity of the cell to be able to repair their damaged DNA. And often it's a combination of the three things together that leads to the aging of our cell, often leading to apoptosis as well as atrophy. This here is a nice summary table. Again, you can also use this summary table. As you can see, it explains the nature of the injurious stimulus and the cellular response that the cell will have. So it's a nice slide here tying everything we talked about together. Thanks everyone for listening, and if there is any question, please do not hesitate to reach out to me via email, or we can also review any of your questions during the case presentation coming up. Thanks again, everyone.